So we still have people joining us, but I don't want to take away from the time that's so important with the commissioner. We also have the Dean of the Honors College, Ralph Keene, with us here tonight, who will continue with the Honors College and the commissioner after we finish with the main section. I want to keep the introduction very brief, but as you know, Allison Arwady is the Commissioner of Public Health for the City of Chicago. She's been with the department since 2015 and Commissioner since January this year. You picked a hard year to decide to become Commissioner, I must say. Previously, she worked for the CDC and worked on issues like Ebola, so she does have a background that prepared her for this difficult year. She's an MD in internal medicine and also a pediatrician. Dr. Arwady, we're so delighted you're with us tonight, and I'll let you make your presentation, and then we will watch Rosaire Rossi, my TA, and I'll try and watch the chat room, and as people put questions in the chat, and be able to deliver those to you. But take it away, Commissioner.
All right, very good, and thank you so much. Check my internet there. Sorry, you can hear me?
We can. It's a little soft, so if you can make it a little louder, it'll be easier.
All right, just making sure the internet connection is good there. So I was saying, it's a pleasure to take a step back from the day-to-day of all the public health work and do a little bit of thinking about, what does this mean long-term? Try to and tomorrow. One of my jobs at the health department is to be always trying to think at least a few months in the future. And honestly, we are really thinking about our COVID response as something that hopefully will impact public health, and think about the future of Chicago, which I know is the topic of your lecture series here, in a way that Chicago can really, our goal is to emerge stronger out of COVID, but I don't think that happens by accident. And I think it happens if we're thoughtful about the ways in which our society is set up has made the way COVID has shown its face here in Chicago. And so I am gonna just see if I can bring up some slides up here. My computer is being a little bit fussy. All right. Share screen. Oh, it says the host disabled the screen sharing. Are you able to?
Let me just make you a host, and that'll be the simple way to solve it.
Sounds good.
So you should now have the ability. It's not showing yet, but.
Yep.
It's coming.
Yep, very good. All right, are you able to see this?
Yes, we are.
Okay, perfect. So my goal is just to high level talk through some slides, but really use them to help you understand how I'm trying to think about these public health issues historically, now, and really in the future moving forward. So we're not going to go through all the details of the slides, can send things around later if you're interested, but they help just frame some of the conversation. And my goal is to talk a little bit about what we're thinking about behind the scenes in public health, help you understand how really the public health response is also an economic response, is also a social response. And then in the end, I'm going to talk a little bit about some of the root causes and some of the way that at the Chicago Department of Public Health, we're trying to use our COVID response to think about long-term issues like the racial life expectancy gap, and tell you a little bit about what we're planning in the future. So I'm sure that'll be plenty, and I'm happy, if questions come up or people want to raise them in the chat box. I don't know how you do it usually, but my goal is not to just talk at you. If we were in a normal room, I'd have more opportunity for interaction. One of the major ways the pandemic has changed us already. All right, so first of all, I think you're all used to thinking about public health at this point in this role. When you hear me, I'm up talking about our testing services or what we're doing around personal protective equipment, around our dashboard, around our data. Just want to make sure this is working. There we go. But also, so much of the public health work that we're doing in conjunction with other agencies across the city, private partners, academic partners, so many others, is not just about the health piece, but about what are we doing to ensure, for example, as you say here, the most vulnerable have access to food, that we're putting together grants for small businesses and nonprofits. There's been thought about helping renters facing eviction, and then this recovery task force. Chicago was the first large city to actually put forward not just what are we doing with COVID, but what does our plan over the next 4 years look like, and how are we hoping to come out of COVID as a stronger Chicago. So there's a lot more to say than I will have time in this short amount of time, but I encourage you, for example, if you're interested in this, to look to the Recovery Task Force. You can go to chicago.gov/coronavirus for all things COVID, including links there. Also, I just wanted to set the stage that there are lots of ways to think about health. And I wanted to help you understand that at the health department, and where we actually look at the major factors that influence an individual's health, there's lots of ways to divide it up, but this is a common one. It's used when counties are ranked for their health across the country. This is the weight that is given to the different factors. So health care, things like, are people able to see doctors? Do they have insurance problems that keep them from having access? Are there healthcare deserts? Accounts for about 20% of health overall. It's important. And of course, the partnership of the public health department with our healthcare system is crucial, as comes to mind with COVID. But really, we think more that some of the health behaviors, so in COVID, sure, that's things like wearing a mask, but this is more about exercise and eating and seatbelt wearing, and all of the things that we put in place to make choices less on an individual level and more the default choice are important, as well as physical environment. And then those socioeconomic factors actually play probably the largest role in terms of affecting an individual's health. And when it comes to thinking about pandemic preparedness, so as you heard in the introduction, I actually have spent a lot of time working in outbreak work. And the good thing is that the way you approach a very small outbreak, like at an individual restaurant, is not really that different on scale from how we approach a pandemic. And this is just highlighting for you what our emergency preparedness team at the Chicago Department of Public Health had led on just last year when we had updated our pandemic influenza annex. And I know this is a lot of sort of government speak. But the idea is that we've done a lot of work to try to have thought ahead and be prepared for whatever might come. And so conveniently, last year was when we had taken a look at everything related to pandemic influenza and had run a series of exercises where we had had a model where actually a disease was emerging from China and spreading, and it had first spread in Chicago. And we actually practiced connecting all of our hospitals. We practiced setting up mobile morgues. We practiced a lot of the policy work that might have to happen. And we pulled together a lot of partners from across the city to think about the potential for trouble when it comes to pandemics. And these were listed on here, all of the sections of our pandemic influenza annex that we had done some work around and said, you know, it's possible that if we were to have a pandemic, you know, like influenza, we might expect to see these things. And what's interesting is that you can see on the list here, every single one of these at this point we have seen here in Chicago. Everything from the food service disruption to obviously educational disruption. We've seen the large event cancellations. We've seen social unrest. We've seen more attention to social vulnerability. The only one that's still pending is vaccine. And I do just want to say, this is not a talk about vaccine, but I want folks to understand there are a lot of questions still about the vaccine and about immunity in general. We don't know how long. I'm very confident there will be a vaccine. There's been such a lot of work on this that once the appropriate science is done, my guess is we will probably have the first vaccine available here sometime early next year, if I had to take a guess, but that it will be a long process over at least a year of rolling out at least one, but more likely multiple vaccines. But it's important, we don't yet know how long immunity may last, either natural immunity or even necessarily vaccine-induced immunity. And we don't know, there is no such thing as a vaccine that is 100% protective. Our very best vaccines, like our measles vaccines, are in the like 99% range. But our influenza vaccines that we make every year, may only be 50% effective, but if they're very effective to help not just in completely preventing a disease, but also reducing severity, preventing hospitalization, which is part of what the flu vaccine does, that is a vaccine that would also be approved. But I think a lot of people think, the future will be here when we have a vaccine, and first that this will be sudden and we'll be past COVID. And I just want you to understand that we are still learning a lot, like every day. We've not been through even one calendar year. There's a lot of concern heading into the fall and winter about what a surge might look like. And we are, of course, thrilled that a vaccine is on the horizon, but we don't yet know. Is this a vaccine that we may need to do booster shots on? Is this a vaccine that will prove effective in different ages? And we have other coronaviruses as examples. I think people probably know, but besides COVID-19, there are many other coronaviruses, including some that just cause the common cold. And many of those, your immunity, if you get exposed, not with a vaccine, just naturally, lasts, 40 weeks. So if people didn't get a vaccine, could we get into an annual outbreak period? Where we look back at our 8 influenza pandemics, they've usually gone 18 to 24 months. So just to say, I don't have a crystal ball on timing. The vaccine is going to be very important as we bring things back, but it is not enough to just think that the vaccine will magically reverse the difficulties that we've had over these last few months. And I want to bring us actually back in time for a minute, because, I love the history of public health and medicine. I have taught on it before. I've taught about the 1918 influenza pandemic, but boy, has it taken on a different meaning for me this year. And this is a sign from Chicago, basically 100 years ago, that this was put up at theaters, that influenza is present and this theater is cooperating. You must do the same. If you have a cold or coughing and sneezing, do not enter this theater. Go home and go to bed until you are well. And this messaging from 100 years ago is actually in many ways still where we are for COVID, because although we've had a lot of medical advances, we're able to provide more supportive care, ventilation, ICU care, et cetera. We still have very limited treatment, specific treatment for influenza. For COVID, we obviously don't have a vaccine, and a lot of the social distancing techniques that we are reliant on at this point are the same ones that we were reliant on 100 years ago. So folks probably are aware of the 1918 flu pandemic. It was the deadliest in modern history. Interesting and important, I think, overlap with World War I, and way more prevalent than COVID has been to this date so far. It ended up infecting about a third of the planet's population and killed somewhere in the range of 20 to 50 million people. And in Chicago specifically, when they hit 250 cases, all of the people with influenza were ordered to go to Cook County Hospital, and then that hospital started to get full, and they moved to this model of isolating at home, which is still the predominant model that we're using today. We've offered quarantine and isolation, but most people isolate at home or are in hospitals. Police were stopping sneezers and coughers without handkerchiefs. One of the most controversial decisions was they outlawed smoking on the L. And influenza became a reportable disease, meaning that there was a requirement for physicians to tell the health department how many cases were they seeing, an important precedent for the kind of data we have today. Once they got up to about 1,200 cases per day, which by the way is about where we were at our peak back in May, when we were under a lockdown, started doing things like banning public dancing and public funerals, and then closed theaters, movie houses, ice skating rinks. They actually did not close schools because a lot of kids got their health care through schools at that point, but did eventually halt all non-essential public gatherings. There were some exceptions in places that they thought had good ventilation. And between September 21 and November 16, had more than 38,000 cases of flu, and then 13,000 cases of pneumonia, which would often follow flu. So we've had about 76,000 cases of COVID diagnosed at this point, just in the city of Chicago, but over a longer time period than this. This, though, was more deadly. So they had the first cases up at the Great Lakes Naval Station in early September, and within 2 months, it had about 8,500 deaths in the Chicago area. We've had here in Chicago about 2,700, 2,800 deaths from COVID. There's been almost that many in suburban Cook County. So, but again, this has been more over 6 months. So not quite the impact that was seen here, but not that far off in some ways. And specifically in the first 2 weeks of October, there was this major spike in flu cases, and they were having hundreds of deaths a day. We never got to a point here where we were having hundreds of deaths a day. At the peak, at least so far, we were having about 50 deaths a day just here in Chicago. But if you include suburban Cook County, it was getting up near 100 deaths a day. They had shortages of hospital beds, nurses, telephone operators. They didn't yet know what a virus was, but strong germ theory, a lot of similar work that we've seen today in terms of mask making. This is something that ran in the Chicago Tribune on the left, teaching people how to make masks. This was the commissioner at the time, and he got a lot of criticism for overreaching. Despite that pretty dramatic death toll, the newspapers referred to him as His Highness, not in a good way. But I also think it's interesting that they, even then, were pointing out some disparities in terms of race and how it was being seen in Chicago. So during this time period, white Chicagoans had an increase in deaths of 2,600%, whereas black Chicagoans were reported as having this increase of 1,400%. So first of all, just an enormous increase in terms of deaths. The commissioner at the time attributed to intrinsic immunity, that there were genetic differences between races. We know that not to be true. More likely reflecting existing disparities in Chicago's healthcare and access. Black Chicagoans already had so much more dramatic rates of death than whites did that the increase was less with flu, but there was also likely differential reporting. There was much less support to the healthcare settings that saw Black Chicagoans, and likely less reporting there. And then this does overlap. The worst of Chicago's flu pandemic was right overlapping with the end of World War I. November 11, 1918 armistice seeded another wave with parties and parades into 1919. And I just want to make a quick point that where we think about sort of what happened after 1918, 1919 pandemic, there is a lot of overlap, of course, with World War I. There were major social changes, as I'm sure you all are aware. And a lot of this is from World War I, but some of it is probably also after effects of the pandemic. I think, you know, here, this sense of sort of having to stay in, and then what happens when you're released. How have we thought differently about what we value as a society? How has technology changed? I think in some ways, sort of looking to the past can be an interesting way to see. So, you know, as you know, the roaring 20s, booming economy, a lot of growth in consumer goods and access. The US really had more financial, economic, and prominence worldwide. I think that is less likely to happen this time around for probably some obvious reasons, but also some very strong anti-immigrant and anti-foreigner sentiment, rise of the Ku Klux Klan at this time, and this is before we had airplane flight, not at any big level, and so but a recognition of sort of transportation as a potential vector for disease. But we also saw a lot of cultural changes, more freedom for women, and some of that I think is that both war and influenza killed many, many more men than they did women. It gave more opportunities for women, and this sort of loosening of social restrictions, partly the end of war, but also potentially partly coming out of this huge pandemic. So when I think about possible areas for societal change after COVID, I'm really thinking, in a number of areas. So one is really in this preparedness space. Public health preparedness itself really grew out of 9/11. So the Chicago Department of Public Health started being funded for any kind of forward-looking planning and work and exercise after the attacks of 9/11 and the anthrax attacks that followed, and just a recognition that sort of as a society, we had not done as much thinking as we needed to about health planning. And I think it's been very clear that Chicago actually was quite well prepared, I would say, by and large, in terms of having done the appropriate stockpiling of, masks and personal protective equipment. But the strategic national stockpile, which is supposed to support at the local level, simply was not restocked after the H1N1 outbreak. There had not been as serious attention as there needed to be in a very practical way, I think, to preparedness. And I think it'll be a long time before we allow that to happen again as a society. But there also has just been, frankly, underinvestment in public health over the years, right? We spend, for every dollar that we spend in health areas, 98 cents of that is in healthcare, 2 cents of it is in public health. But I do think also this has really raised manufacturing and international supply chain vulnerabilities. So I know you've all heard a lot about PPE, but kind of behind the scenes, where we were having a lot of the biggest trouble with accessing was around a lot of the supplies actually for testing, and not even the reagents, but things like the test tubes. These are not things that we had stockpiled, and it turned out that China did a lot of manufacturing of this, but the very particular region of Italy that was very hard hit turned out to be the supplier for a lot of what was needed kind of in the testing frame. And I think it really highlighted that if you're going to think about a true pandemic, as in something that affects across boundaries, you need to be thinking about your supply chains in ways that mean you have thought more ahead than I think we had, particularly where it came to the issues of testing. I do also think, the questions I get, some of the questions I get the most about what do I think is going to happen post-COVID are these social questions. Are we going to stop shaking hands? Are we going to stop hugging? When is that going to come back? And then the wedding question. The question, everybody wants to know, when can they have their wedding? When will it be safe to have their wedding? And neither of these have, definite answers. But what I do know from having worked, in other outbreaks, in other settings, is that very often people get used to changing their social behaviors, right? I hope everybody on this call has at some level gotten used to putting on a mask where you go out the door, keeping your distance wherever you're able to, protecting vulnerable residents, et cetera. I do think it's going to be a long time till we're shaking hands again, but I can tell you that, for example, I was in Liberia a number of times during the big Ebola outbreak back in 2013, 2014. And that whole country just completely stopped touching, right? Stopped shaking hands. And at the time, it was so amazing to see how quickly that happened, and burial practices changed. And then once Ebola was sort of over, pretty quickly, all of that came back. But then here came COVID, and I have a lot of friends who still work in Liberia, and it was pretty easy for them to turn on a lot of the practices related to the social distancing and the temperature checking and the bleach to make sure, that they use for some of the hand washing. And I do think we'll be in a different place in terms of probably much more hand washing, hopefully, at least for a few years here. And thinking, in flu season, I think we're going to see masks at some level, much more than we have, probably even in a long-term way. But I do think that fundamentally we are going to get back to all of the normal ways in which we interact in the more long-term way. I do also think, obviously, technology, as we've seen, in other spaces, just is driving a lot of the thought here in very important ways. Obviously, the Zoom factor, right? Here I am at home talking to all of you, and the idea that a lot of work that is able to be done virtually has been experimenting with being virtual, I do think has the potential for major change, and some change that could be potentially problematic for cities, where we think about large corporate headquarters. And there's been a lot of work on the economic side to both think about this and how do we mitigate it. I do think that Zoom fatigue is real, and certainly where we think about schools, I do not think, this online learning is in no way the ideal, and is not something that we're going to, have a full scale return to. But I think, might snow days be a thing of the past, like for schools? They might be down the line. Will we likely see much more flexibility in terms of how we work? I think definitely. And then the other thing is just the amazing role that social media is playing here. Combating misinformation, sharing good information, that is emerging to be a major focus and need in all kinds of interesting ways. And then in the policy space, so this has highlighted lots of cracks, right, in our social safety net, and I think raised some questions. We're more likely here in the U.S. to do these large kind of bailout type programs and the supports for the economic stimulus packages, et cetera. Many other countries do more investment in a social safety net in a more long-term kind of way. I think that's always a little bit of a struggle, but this has raised here the many ways in which people do fall through that social safety net. And although we've seen ways that Chicago has stepped up here, I think it highlights it and it really motivates, I think, potentially fundamental conversations there. Certainly healthcare system interoperability has come to the fore here. I think one of the reasons that we have had more challenges here in the US around COVID in part just has to do with the fact that our healthcare system does not talk to itself. We do not have universal healthcare, but even without that, if we had the ability to understand whether people had had COVID tests, no matter where they'd been, we had the ability to understand underlying conditions and more ability to share across health systems to provide good health care for people. It's been a gap. It's one that certainly CDPH with many of our hospital partners have worked hard on here, but I think that has shown itself to be an issue and one that I think we'll see some major changes in. I think just the fact that we still continue to have health insurance for almost the majority, it's about 49% last I checked of Americans, your insurance is tied to your job. And then where we see a lot of people losing jobs or moving to part-time, not having insurance, I think it's raising additional questions in that space. Certainly sick leave and family leave policies couldn't be more obvious, where, we've really seen pretty clearly that people who are working in jobs where they don't have sick leave available will continue to work when they are sick. And that has major potential for spread of disease. And we've been trying to figure out kind of behind the scenes, how do we work on those issues? But I think infectious disease is a good way to remind people that you don't want folks actually working when you're sick, but how do we support that? How do we pay for that? Similarly, unemployment benefits, I think there's interesting conversations happening about what should those look like? Should those be redone? The digital divide, obviously, lots of work, for example, Chicago Public Schools, but many others too, working to really get the internet widely available here. And I think highlighting, the fact that so much has been virtual has just highlighted the need to work on that issue. Design itself, I think we're going to see differences in terms of how we think about, ventilation, healthier buildings, probably for some time. Transportation plays a role, and then a lot around international collaborations, agreements. What does it look like to actually have an international standards around pandemics and sharing data and sharing responses. The WHO is the existing body that most serves that role, but I think there's a lot of politics, obviously, within how the U.S. has made a decision to not support that currently. But regardless of what role that plays, I think, globalization, although we might see a slight, because of COVID, there will be a downtick in international travel for some time, as we've seen, you know, that's not going anywhere. And so thinking about how we keep some of these public health pieces as we're thinking about international, I think are some spaces where we're going to see some changes. And so just to kind of get into a little bit more about COVID and kind of the health department and some specifics around health. So I think everybody on this call is probably aware of the really significant racial and ethnic inequities that we've seen related to COVID. On the left, this is our pandemic curves by race, ethnicity. In purple at the top there are Black, non-Latinx Chicagoans who make up 43% of the cumulative COVID-19 deaths, although they only represent 30% of Chicago's population. And then similarly on the right, where we just look at cases, you can see that cases have been disproportionately among Latinx Chicagoans. 48, I think it's actually up to 49% now of the cases have been in Latinx Chicagoans. And so if we're going to think about this seriously, it's about, you know, what is putting Black Chicagoans at higher risk of death? What is putting Latinx Chicagoans at more risk of acquiring COVID? And how has our society been set up in a way that has made that be an outcome? And so, you know, one of the good things I think that we've learned from COVID is all the ways in which neighborhoods, community organizations, philanthropies, individual Chicagoans have really stepped up to fill gaps. So, you know, these are some of the food and PPE distribution sites. We've seen a lot of really good, I think, cooperation. We've also learned a lot about how to better coordinate in this space, better coordinate in the food support space, in the housing support space. In many of the other spaces, I think the pandemic has brought to light, you know, where there are gaps, where there are challenges. And I think we have made some real progress that I very much hope we will build on. And every intent is to continue to build on it sort of post-COVID. But I also think, frankly, that the call for racial justice this summer is in some ways also, it goes right along with the pandemic conversation. And the fact that we've seen, you know, real linking of, you know, I'm sure people have heard the link between talking about both the COVID, you know, the COVID injustices, but also the racial injustices. How are these linked together? And I think that this movement coming, you know, at the same time, this same summer, I do think those are potentially related to each other in some ways. And I think that they will continue to be sort of this twin pandemic, if you will, that we will be thinking about, I think, in really important ways as here in Chicago and across the country, as we kind of take on what have we learned from COVID and what are we going to do with it. I do want to highlight that we are very much, you know, following along with the health indicators that I presume you all have been following. There are economic recovery markers that we're watching really closely. These are from Samir Mayakar, who's the deputy mayor for neighborhood and economic development. But they're just showing, these are Chicago small business data specifically from University of Chicago Poverty Lab has been helping with this. But you can see on the left that where we look at the trend of hours scheduled across small businesses, right? We had this huge drop down with the stay-at-home orders. And then, you know, a slow recovery back to, we're at about 64, 65%, and that's continued to rise a little bit in September. And similarly, firm closures, we had almost half of the small businesses closed under stay at home. We're down to about a quarter closed. So a long way to go, but following along. We have had some outpacing of the small business recovery, at least so far, compared to other cities. Our trends of hours scheduled at this point are 27% down as compared to January. Which is better than in these other cities, and so is the number of employees, but we're still 25% down compared to January. And we have really worked here to try to allocate a lot of support to small businesses, and really nearly 3 times the support of the next most active large city. Of course, the amount that the city is doing here is relatively small in comparison to what the federal government is doing, but we've really tried to push resources into spaces where federal loans were and grants were less likely to reach. And so this just highlights, for example, where, you know, I am very grateful for the significant federal relief that has come. I'm very hopeful that we will see another package get passed very soon here. But PPP loans, for example, if you look in Chicago, the darker up on mostly the north side show where PPP loans went in Chicago per 1,000 businesses. So the Chicago Small Business Resilience Fund instead, right, has focused on small businesses on the south and west sides, which, you know, are predominantly the more predominantly Black and Latinx areas of the city. And similarly, spending growth is actually, you know, it continues to grow. We continue to do a little better here, but there's a long way to go. The reason I show you all this is to make the point that we are, oh, sorry, and here's the residential properties are actually doing very well. We're at historic lows in terms of vacancies for detached single family homes, and the attached single family are stable. So it's a mix of sort of how is this hitting in different sectors, and we have a very diversified economy here. So really the hope and the plans is that we will not just weather this, but the goal is to really come out stronger, and there's a big work around this. But I highlight this again to make the point around, you know, our zip codes that have been most impacted by COVID, you know, go right along with the zip codes that are predominantly Black and Latinx, and it's illuminating these pre-existing health inequities. So some of you may know this, but if you don't, I wasn't gonna give a talk without highlighting the racial life expectancy gap. So we have seen increases in life expectancy decade after decade after decade here in Chicago and across the US. And only in the 2010s did we start to see that life expectancy fall, not just in Chicago, but around the country. We spend more on healthcare, much more on healthcare than any other country, but our health outcomes are not as good. And this is a big deal. Like if you're following how healthy is a city, how healthy is a country, seeing a drop in life expectancy is a major red flag. But when we break down what was happening, where we went from a life expectancy of 77.8 years in 2010 to 77.2 years, which has, you know, and that has continued to fall through 2020. When we break that down, again by race, here is what that breakdown looked like in 2012. So Asian Pacific Islanders in Chicago living an average of almost 86 years. Latinx Chicagoans living 83, white Chicagoans living almost 80, and Black Chicagoans, major gap, 72.6 years. When we follow this forward, what you see is that the only group that continued to gain in life expectancy was the white non-Latinx group, and that has continued. The drop in life expectancy across Chicago is driven by all three of the other major race ethnicity groups. So you can see that Latinx has actually fallen the most from 83.1 to 80, 3.1 years, just in, you know, 3.1 years of life expectancy drop over just 5 years, and below white life expectancy, similarly among Asian. But the biggest difference here is, again, that gap between Black Chicagoans and other Chicagoans. And you see that although the gap was already very big in 2012, it only grew as we went forward in 2017. And it is now an 8.8 year gap. What do you think's driving that? Think about that for a second. I'm going to show you. But if you had to think, what is driving the racial life expectancy gap? Why do all, you know, taking all comers in Chicago, what are the actual causes of death that are written on the death certificate that make up that life expectancy gap, that are most different between Black Chicagoans and other Chicagoans? Chronic disease, number one, half of the gap. Homicide, infant mortality, still after all these years, HIV and other infectious diseases, and this is where, you know, COVID would fall in, and opioid overdoses. So these 5 indicators are the proximal cause that is driving that life expectancy gap. And the health department has developed a lot of programming very specific interventions and work in each of these spaces. But when we sort of go upstream and we think about Chicago's racial life expectancy gap, that's mortality. What is actually driving that are the diseases and injuries. So chronic disease, homicide, infant mortality, infectious disease, overdose. But what is actually driving that are risk behaviors. And these are things like smoking and poor nutrition, physical activity, substance use, sexual behavior. But what is driving those are much more about these living conditions, physical, social, service access. What is driving differences in those? Institutional inequities, right? Laws, regulations, policies, practices in government agencies, businesses, schools, not-for-profits, and then what's driving some of that? Social inequities, racism, discrimination based on class, immigration status, ability, gender, sexual orientation. And so if we put all of this kind of together and think about it in COVID, so we see big differences in terms of who is dying from COVID. That's your disease. Your risk behaviors, sure. This is things like, are you wearing a mask? Are you socially distancing? Are you able to follow the health guidance? And that is very important. And one of the most important things where we think about COVID outcomes. But what actually drives your ability for for changing your risk behaviors? It's safer to stay home, work from home, but the living conditions, we've done a lot of work, and there are things, and this won't be a surprise to anybody on this call, but there are big differences in terms of where do we see the most crowded housing in Chicago, there's a definition for that. Where there is crowded housing, it is much harder to quarantine or isolate within your home. It is obviously much easier for people who are doing the kind of work that you can do online to do from home and work virtually. And we see patterns that match the geographic spread of COVID that overlap with the essential workers. We think about what kind of access there is to services. We think about living conditions. All of these really underlie, in many ways, what those risk behaviors are. And then, the institutional inequities come even more to light, where you're like, what have you put in place? And certainly we work to try to push resources where they're most needed. But if you're in parts of, where there's not access to healthy food or safe spaces for exercise, and that leads to chronic diseases, and then chronic diseases put you at higher risk for bad COVID outcomes. It's like, what is driving all of this underneath? And so that's some of what we're trying to think about. And so overall, there is as much as a 17-year life expectancy gap between community areas in Chicago. And that is unacceptable and absolutely something that we should be working on as a city, as a health department. And again, here's some of this root cause work where we look at where obesity differs. And we know that obesity is a risk factor for COVID and COVID death, where we look at where there are perceived unsafe neighborhoods, and we think about that as a root cause for lack of exercise, where you think about that as a root cause for chronic disease, where you think about that as making people more likely to unfortunately have severe outcomes if they die from COVID. You think about food access barriers. On the right, here's your percent of people with low income who live at least a half a mile from the nearest good place to get food, particularly if those are matched with transportation barriers, as they often are. And so we've set out at the health department something called Healthy Chicago 2025, which is a 5-year plan, but is really meant to be thinking in a generational kind of way. How do we work on some of these root causes? How do we talk openly and honestly about the racial life expectancy gap, those 5 main drivers, and what are we going to do about it? This is the vision that was put together with hundreds of community partners, a city where all people in all communities have power, are free from oppression, are strengthened by equitable access to resources, environments, and opportunities that promote optimal health and well-being. Very based in root cause as opposed to healthcare. And here's some of the goals and some of what we're thinking about, and what I would encourage, all of you, depending the areas that you work in or the areas that you're studying. There's much more if you want to learn the details of some of this. But if there are pieces in COVID that have caught your attention and made you want to think about policy, made you want to think about changing, the way we do things as a society, I would encourage you to, you can link into some of this and think about where it will be. So this is about, to close the racial life expectancy gap. We've committed to really working to improve systems of care for populations most affected by inequities, further the health and vibrancy of neighborhoods, strengthen community capacity and youth leadership, and transform policies and processes to foster anti-racist multicultural systems. We had actually set this Healthy Chicago 2025 goal plan. All of it had been done prior to the COVID outbreak. And I think it's a testament that, COVID has just brought all of this inequity so much to light that people are now interested in this or seeing it in a different way than they were previously. And so some of the priority areas that we've set out as the city, but also with partners. This is not just CDPH. The idea is, how do we work on these things? Really thinking about inequities in housing, in food access, in environmental health, in public safety, neighborhood planning and development, health and human services, and then sort of public health systems and organizations. And, again, a lot of this, you might say, how much is this public health? How much is this? All of this at some level are the things that most impact public health. And even though health and human services, it's only one bucket there, we really, if we're going to be serious about, the future of Chicago and the future of like having a true healthy Chicago, we think it's about these spaces. And so we'll be having particular focus and pushing resources. There's data that you can point to online for where and how some of these are determined. And then setting an ideal state. I'm sure you've all heard Mayor Lightfoot has really very much led the charge on here in terms of thinking about which neighborhoods have been disinvested historically. What are we going to do to really address poverty and the wealth gap, ideally within a generation? So this is kind of the health view of that within one generation, this is an ideal state, but setting out in a really positive way that all Chicagoans could have a healthy, affordable home, could have enough nutritious food, and local food businesses thrive. It's not just about access to food, but supply chain. Could breathe, clean air free of harmful pollutants, are safe across the city, have trusting relationships with law enforcement, live in vibrant neighborhoods that reflect their identities, benefit from a full range of health and human services, and then have voice and power in the public health system. And then that brings us to the vision that I laid out. These are the guiding principles that we have used, and encourage others, if you're interested in kind of being part of Healthy Chicago 2025, thinking about the health of the city in the next 5 years, but also in a more long-term way, not just physical health, not just mental health, but economic health, social health. Really trying to think about having, we try to be anti-racist, try to call it out with that term. I think it's a hard word. It makes people sometimes feel uncomfortable, and I think that's appropriate. And we chose that word on purpose. So actively challenge and redress racist systems through our process and strategies. I'm a white woman. I am not the person to try to speak to the experience of Chicagoans of color, but I do want to use the platform sort of the health department and of our work to use data, call out where we think there are, have been, and continue to be racist systems. How can we identify those, talk about those, and then have that be part of any plan to address them. Also, we try to be asset-based, really highlighting community strengths. We've tried to do that in COVID. It's not just about where is it bad, where are there places that may have higher economic hardship but are actually doing very well from a COVID perspective, what is different in that neighborhood. Equity focused, thinking about who benefits and who is burdened by solutions. Trauma informed, that's been obviously very important in a time of COVID, but it overlaps the violence work and the mental health work and so many others that, trauma affects everybody. Thinking about how do we support resilience and healing. Capital building, promoting community wealth, affordability, and belonging, and then community-led, really trying to make sure the community members, including youth, have real power in making decision-making for their communities. And so here's just one example around food access. Like, here's some of what's already happening, where we're publishing a food environment map. There's a food policy initiative, an advisory group, really thinking about kind of food equity and justice. This is about, how do we support local food producers and businesses? How do we think about hiring in this space? It's just to kind of give you a flavor of it. There's much more online. We'll be measuring progress with an equity dashboard. And we, I mean, the city of Chicago. And, you know, thinking about that life expectancy gap, the health status overall, economic well-being, and mental well-being. And just, you know, this is my end here, that where I think about how are we going to use COVID for long-term here in Chicago. Wherever we're investing, wherever we're using our COVID dollars here, I am trying to think about, yes, addressing the COVID needs, but also building up a workforce and sort of more community capacity, particularly in the neighborhoods that have the longstanding chronic disease issues. So for example, our community-based contact tracing core, I'm not sure if folks have been following this, but most cities and jurisdictions around the country, the great majority, when they needed to really expand contact tracing, moved to using a phone bank or partnering with a university, partnering with a health system. There's a lot of ways to do this. And what we actually did, and what we're still doing here, as we head into fall and winter, is we're expanding our ability to do contact tracing. Specifically, we put out what's called a request for proposals, identified a lead agency, which is the Chicago Cook Workforce Partnership, which, if you don't know it, is an organization that its whole goal is to sort of build up the workforce, make sure people can get connected to work, support people in getting the skills they need to move toward work. Important engine there. And they in turn have selected 31 community-based organizations specifically from the neighborhoods in Chicago with high economic hardship. So on the west side, on the south side, these also are the communities that have been hardest hit by COVID. But the idea is that those community-based organizations, first of all, are community-based organizations that we want to partner with in a, you know, we already do in many cases, but we want to fund them. We want to make sure these important sort of fabric of communities make it through COVID well. And are importantly hiring people from these same communities. We said there's no education requirement. We're most interested in hiring folks who have had prior barriers to employment, pushing, you know, it's only 600 jobs, but it's 600 jobs we have some control over. Let's push them to neighborhoods where they're most needed. And then there's an earn as you learn component where anybody who's being a contact tracer through city colleges in Chicago is also getting free of charge additional skills and coursework in other health things. So community health worker type work, or even phlebotomy, blood drawing, links to our federally qualified health centers in those areas. So in addition to kind of supporting the community-based organizations, we've invested in our clinics, our federally qualified health centers across the city, particularly ones that support a lot of people who are without insurance or are low income, and help make sure that they too are part of case investigation and contact tracing, so that yes, we are addressing COVID and making sure everybody gets case investigation and contact tracing. We've been doing that, you know, for months and months, but moving that work into community and recognizing that then having a workforce that will hopefully be able to outlive COVID, whether they're connecting to the health system, if we are able to get additional funding, which I'm hoping we will, to support chronic disease, resource coordination. This can be really coming from neighborhoods, from points of strength. And we can do a lot of that preventive work around chronic diseases that we actually really need to work on as a city if we're gonna work on the racial life expectancy gap. So really my goal here was to help you, you know, just think a little bit about how at the health department we're thinking, you know, using the past and that, you know, 100 years ago in a lot of ways, I still, you know, it's taken on a whole new meaning for me where I read back in some of this. I was on a conversation with folks across the country, and people said, well, you know, in 1918, they canceled Halloween. We're not canceling Halloween, but we do sort of look back to some of these big pandemics for examples, but also thinking about our current response. And then where I think about the future of Chicago, I think being really honest and working on root cause work and calling out this long history of racial inequities, and then working together, right? Like the health department, the city, as in city government, are a tiny piece of this, and really asking, all of you, even as you're thinking about your careers and your research and what are you going to work on, if some of what I've said is interested to you, I encourage you to join us on social media. chi.gov/CDPH is our website. You can find more about Healthy Chicago 2025. You can get involved. But regardless, think about sort of COVID-19. It's a hard time for everybody, but I think it has also exposed a lot of the stresses and the cracks in society. And there will be some opportunity, I think, post-COVID, as we've seen post other major societal disruptions, to think perhaps differently about some of these issues. So thanks very much. And I appreciate the attention and thoughts. I'm sorry that, I wasn't able to be in the room and take live questions.
Thank you very much, Commissioner. It's a wonderful talk, and I think has inspired a lot of thought on everybody's part. We have about 10 minutes with this group, and then we're going to switch to just the Honors College students in a little more intimate conversation. But does anyone have questions? And maybe you could start, if you do, put them in chat, or after the commissioner finishes answering the first question, you can simply unmute yourself and ask your question. We have time for about only 2 or 3 or 4 questions in this segment. Commissioner, you were ending on what the 100 or so students who are on this call might do. I wonder, out of all the things that you did say, what would you recommend as steps that any of the students, whether they're studying health or studying politics, might do at this time?
Yeah, absolutely. So I think there's a lot of things. One is just please, please, please be politically engaged. And I'm sure that this group largely is. But I think, some of the real basics like voting and census and making sure that we are doing everything we can to promote these, some of these basic things right now are also just a key part of being an engaged citizen and having your voice kind of play a role. I also would encourage people to get involved with an organization at the community level here in Chicago if you have time. I know, you're all busy and there's a whole lot going on, and, there's sort of campus pieces here, but I think as much as you're able, and it's hard during COVID and there's all these things, but there's such a lot of interesting work happening right now, I think, across this city in the ways that community-based organizations are sort of using their voice, solving problems, coming together around neighborhoods. That is one very particular way. Also, if you go to our website, you can download the plan and whatnot, but you can also actually sign up to be on kind of the list where we send out lots of opportunities and also many opportunities for younger people. You heard there that we're very interested in youth voice, and there are plenty of opportunities to get involved in focus groups and roundtables and outreach. And if you get on our list, we don't bother you too much, but we'll let you plug into some of this even at the direct level.
Thank you. We have time for several questions before we break just to the Honors College. So do some of you have questions?
I have just a comment. I wanted to, hi, Dr. Arwady. I was in your Fundamentals of Public Health class in the fall of 2019 at UIC. And I just wanted to say thank you. And I'm so excited to see the Healthy Chicago, being just so useful still. You had talked a lot about it at the time, and it's nice to see it moving forward. So thank you. That's all.
Yeah, it's great to see you. Right. Like, I think, the things that we talked about in that class, I talked about history, I talked about some of this work, they've all just come to much greater societal attention.
Absolutely.
Than we possibly had. And so anybody on this call who is in sort of that public health space, that space, you know, this opportunity to kind of raise your voice, like what does that look like, right? At this moment, even while you're students, I think it's a moment to sort of tell stories, to, you know, to kind of get the word out, and, you know, and use some of this framing. So yeah, it's great to see you. And that was at a time where I was not anticipating any of this.
None of us were. All right, thank you.
There is a post in the chat, someone who's interested in pursuing an MD and has a passion for public health, and have always wondered if how they could be involved in both as a career. So it's inspiring to see someone like you, but maybe you have some comments about those that might want to pursue a similar path.
Yeah, absolutely. So I think, you know, I love folks who are interested in this sort of intersection of public health and medicine. It's a very particular focus. I want to be clear that you can absolutely have a fantastic career in public health without an MD, without medical school. And so you want to be, you know, I was very interested in sort of this connection. I actually continue to see patients. I only see patients right now once a week, but some of my long-term interests are really about kind of bringing together some of that very specific like health care work with the public health. And, you know, I've got long-term interests that go beyond it. But I think if you end up going to medical school, definitely keeping your eyes open for opportunities to intersect with public health. For example, I had a big public health interest even before I went to med school. And so I made sure that, you know, that you have one summer of an elective, and I was careful to do that, you know, in a public health related field. I actually ended up taking a year off from medical school to do, the first time I worked for the CDC was actually as a student. I knew, you know, I was debating, was I going to be in infectious diseases? Was I going to be more in the public health space? Sort of keep that interest up during that time. And then there are definitely a lot of opportunities through the CDC and others, not just for physicians, but for veterinarians, epidemiologists, other public health students. If you're interested in some of the applied work of public health, that can be a good place to start. And there are short-term like rotations for students. There are longer term trainings. I did a 2-year training, for example, after I was done with all of my medical training to do outbreak response. That was kind of the beginning of my, you know, my focus in terms of this line of work. But I think they complement each other well. You can do a lot of public health work as a physician, even without the MPH. You can sort of work between these spaces, but I do think the public health training is important if you're going to really want to have a long, you know, kind of a serious career in public health, making sure you've got those basics of epidemiology and biostatistics, you know, the environmental health, all of these pieces together, I do think are important. So, you know, there's lots of orders in which you can do this training, or, you know, there are ways to learn on the job, but I encourage anybody with interest in both of those to really pursue it, because we need folks who are in healthcare with a public health interest, and vice versa.
We have time for one more question or comment. There are a number of people thanking you on the chat line, but I won't read all of those. Any last question as we end this segment? Thank you very much, Commissioner. And I'm going to turn it over to Dean Ralph Keene from the Honors College and ask that the Honors College students stay, and if the rest can end, so there can be sort of a smaller group to talk with the Commissioner from the Honors College. Dean Keene.
Good evening. Thank you. Thank you, Dick. Thank you, Professor Simpson. Welcome, Commissioner Allwady. Students, I don't think you need a whole lot of extra introduction for the Commissioner from me. She has been at the very forefront in keeping Chicago and Illinois safe ever since this started. You heard her credentials at the beginning of the presentation. Dr. Arwady, let me introduce to you the students, some of the students in the Honors College. This is a group that everybody at UIC is tremendously proud of. This is a segment, this is a student body of almost 2,200 students. If we were an independent liberal arts college of this size, we would be among, on the merits of the students, we would be among the top liberal arts colleges in the country. It is the most diverse honors population of its sort in the country. And what's particularly special about this group, apart from their diversity and their achievement, is that it's a community. And even in this remote state, they really do have a very strong, it's a tight-knit, committed community of students, most of whom come from the region and who want to give back to the region, whether it's in their professional lives, whether it's through activism and engagement. And it's a really special group. And I'm here with several of our advisors and assistant and associate deans. And we're just all really, really delighted to have you here kicking off this season for us. So students, meet the Commissioner of Public Health for the City of Chicago, Dr. Allison Arwady. Commissioner, the screen is yours.
All right, thank you. So first, when I heard that there was an opportunity to have a little bit more interaction with students, I said, yes, I'm definitely, I'm busy, but I always like to make time to talk to students, frankly. And especially, folks like you who are, I think, some of probably the best of what Chicago has to offer. And where you're thinking, I hope a lot of you end up staying in Chicago, thinking about making your careers here. I think of, you as hopefully future colleagues, future partners, in a long-term way, no matter what field you end up going in. And so I, as you heard, I'm an adjunct assistant professor. I've helped, kind of co-teach some of the evening classes in the School of Public Health. I really like UIC. We have an academic partnership between University of Illinois at Chicago, specifically the School of Public Health, but and the Chicago Department of Public Health. That's our only formal academic partnership, and I really, look forward to answering the questions and just having some conversation. And I know you're having a very strange year, and I proud of you for hanging in there and, doing all the things and, being as resilient as I know you're being, and what was not your plan for this year.
I think it's useful if some of you would tell her a little about yourself and then ask questions that may be, helpful for you as you go forward. I've never known you to be this shy. Go ahead, Chrissy. Your sound's not coming through.
So many places to mute yourself.
There you go.
Okay. I'm a sociology student, Dr. Arwady. It's really great to have you talking with us tonight. Really appreciate it. I have a question that's about the city's reopening plans. It's been really reassuring to be in Illinois during this time, and in Chicago in particular. And I'm curious what kinds of data you all have been using to guide the decisions to open indoor venues to a larger extent, while we still have some outdoor places closed and schools still closed. And I'm just curious how you all are balancing those things.
Yeah, sure. So, there's the science of public health and the art of public health. And I come very much from the science space, the data-driven space. And in fact, I think one of the reasons why our outbreak has broadly, at least to date, been in better control here in Chicago and in Illinois than it has in many places around the country is that we've actually been pretty strict with our data kind of requirements and thinking about the restrictions that go in place. And so if you're interested in some of the details of the data itself, I would refer you a couple of places. One is on Wednesday, I did or was it on Wednesday? What's today? Wednesday? On Monday. On Monday, I did we did a press conference talking about the details, but also, and I can send a link maybe if we want to do this afterwards, I can send it tomorrow. I do if you guys don't know, I do a Facebook Live, really at least a couple of times a week, taking questions directly from the public. But then I also use that opportunity to kind of dive more into data every single day. And so yesterday, I did a kind of deeper dive, 15 minutes at least through the data. But at a high level, here's how it works. We follow 8 different indicators at the Chicago Department of Public Health that we use to make our decisions around kind of reopening. And the ones everybody always thinks about are our number of cases and our percent positivity. But along with that, we follow emergency department visits for what it's called COVID-like illness, what looks like COVID even before people are diagnosed. It's something that we do for flu. It helps us have an understanding of kind of what's happening before people are getting tested. We follow hospitalizations, we follow deaths, so severe outcomes. So there's those. And then we follow what is our response capacity. So, do we have enough testing? Do we have enough hospital beds, basically? And do we have enough public health, contact tracers, case investigators? And there are very specific metrics that are laid out for phase 4 that are in a red, which is stop, there is no way we are moving ahead. And in fact, we may need to move backwards. And they're all defined with numbers or with amounts of time. There's yellow, which is sort of pause, we can't move right now. And there's green, which says, okay, we're in a phase where we may be able to move ahead. And so I'm not going to get into kind of all the details, but on cases in particular, because if you've been following along in Chicago, we would really like to be below 200 new cases per day in Chicago, because that would put us out of a high incidence state, sort of as defined by CDC. We would really be feeling much better about where we are. We really don't want to get to 400 new cases a day if we can help it, because that puts us in kind of a red zone. It puts you on the bad list from a federal perspective. It's the level at which it's the equivalent for Chicago's population where we require quarantine, right, for other states. And so we have been sitting in this 200 to 400 zone kind of all summer. And the definition for sort of where we could move ahead and advance progress on cases was either sustained under 200 cases or at least a 28-day of stable or declining case rates, as long as you hit everything else. And so we peaked here August 24th. We were going up. August, we got up to about 360 cases, very close to 400. And then finally in the last month and more than 28 days, we're able to turn that around and got the percent positivity back under 5% and got these other things in place. And when we hit these metrics, we set them out and we said, this is what allows us to potentially relax. But we relaxed kind of carefully, if you noticed. We went from 25% capacity to 40% capacity. We said if we're doing well in another 28 days, we'll probably go to 50% capacity. The indoor-outdoor, some of that is actually where state and city regulations come in. The city is allowed to be stricter, but not less strict than the state on anything. That's kind of the way things are set up. And so there are, in terms of stuff that's not open outdoors, is usually because they're running up against the state restrictions that, outdoor gatherings of 100 people, or there's some other things that play into place. More of the space that we've worked in has been the higher risk setting, which is the indoor setting. But I was very pleased to be able to make some careful, all we basically did is took Chicago back to sort of where much of Illinois has been. But we laid out in a lot with very specific data and metrics. You can go to chicago.gov/coronavirus, right up at the top, latest data. You go to reopening, you'll see the details. And we follow along every day. So if you're curious about the data, take a look and join us on Facebook if you like. And we'll keep, we'll keep using those same metrics as we make decisions. And if we get into a bad surge, right? COVID is just not behaving necessarily in the way that we would have expected it to. We'll use those same metrics if we have to pull back. But things have looked good at this point.
Irvi, I think you were next. If you want to unmute yourself.
Yeah. So obviously over the summer, because we've had good weather, we've been able to move a lot of the indoor activities outdoors, such as dining. How is this gonna look like once the cold weather starts to set in, and how is this kind of gonna impact all the businesses?
Yeah, exactly. So this is, again, this sort of balancing, right? So again, I'll give you a little behind the scenes view. So every morning, usually at 8 a.m., I have a call with the mayor, with her whole senior team. And the first thing we talk about every day is what are our COVID numbers and like, what are we doing on COVID? Because everybody is well aware that like keeping COVID in check is key to like us being able to move ahead and be successful as a city, right? And so every Saturday we have a like long drawn out meeting with the mayor and again, kind of all of her senior staff and her economic folks. And we really look at where are we, what decisions are we gonna make? I've been very appreciative here that you know, we set out some very clear metrics, as I was just laying out, that we have really stuck to, because those are not, you know, if you, I'm sure there's folks on here who study epidemiology or public health, like when you are on an increase, that is not a time, right? You just, much as I might like to be like, yeah, let's open it, you cannot do that. Like you need to make sure that you're sort of on a real decline, you understand what's driving that, you have enough access. And so, you know, the move this week to gently, you know, to loosen some of those restrictions is this dial. Our goal is to move this dial so that we don't have to take really big jumps backwards and we're able to sort of move ahead more carefully. We are actually the largest, we're the most open large city. So New York, Los Angeles, you know, don't even have, well, New York just brought its indoor dining back, but many places, you know, have not really had it at all, where they were having sort of more of the second surge. And so this move from like 25% capacity to 40% capacity for indoors and letting the bars come back at 25% capacity, I mean, these make me nervous a little bit. And of course, if this were a pure public health, like the opposite of my talk I was just giving, if my only goal was to only think about health, I would say everybody has to stay in at all times, right? But we know that that's not A, possible, but also B, there are very real economic things that we're also thinking about here. And so we put the health first and foremost, but part of the reason we're expanding a little bit now is it's getting cold and we want to see sort of how it goes. We were not expecting a big surge in the summer like was seen in a lot of places necessarily. And some of that had to do probably with that in very warm places, people are indoors more in the summer, right? Than they are in the winter from an air conditioning standpoint. But even so, this virus has just been behaving in strange ways. It's not followed the patterns that we would expect, you know, from a flu, and we just don't know, right? Like I would feel more comfortable if I were sitting in Los Angeles and had to get through the summer, and I mean the winter, and could just say everything, you know, outside. That's not a reality here. And so we've been working instead to try to think about how do we create our indoor spaces to be as safe as they can be. And what's really different now in the pandemic than it was back in May and kind of first surge is that first surge was very place driven. It was a lot of like settings of concern, a lot of outbreaks in long-term care facilities. In the jail here, we had a very big outbreak. Some of the homeless shelters, some of the very, like the large workplaces, factories, et cetera. And that's some of what we saw in the data, right? That also underlies it. We've actually learned an awful lot about how to keep those risky settings in good control. And we've learned a lot about how to have offices and like we've sort of learned, you know, you wear your mask, you keep your 6 feet, your ventilation is halfway decent. You're actually pretty well protected from COVID as long as people can do those basic things. And so now only 5 or 6% of our cases in a given week are tied to like one of these congregate settings. And they're now much more in the private setting. Like people are getting together in their homes with their friends. In, you know, you feel safe around the people that you love. You always think COVID is the other, right? People are very worried about public transportation because I don't know those people and I'm going to get like, no, like where we actually see more concern are in these sort of individual social gatherings. So we know those are going to happen. We would like to get through this in as economically unscathed a way as we can, but everybody recognizes that if we don't keep this in as good control as we possibly can, first, and most importantly, we'll see a real surge in hospitalizations and deaths, which I'm sorry, like that is the ultimate like fail, right? Like this is what this is about at the end of the day, but also that would have a secondary effect of putting us way backwards economically too.
There's a question in the chat from Ashley. With the research you've done, when do you have any predictions on when quarantine will end, and does that depend on the vaccine getting released?
Yeah, so couple things on that. So I would say, and I hit this just very, very briefly. I didn't want to make it a whole talk about the vaccine. I expect that we will, there are 4 vaccines that are now in phase 3 trials in the US, which means they're in the phase of trials that are enrolling many thousands of volunteers and are testing in the real world, do these vaccines work and are they safe? It takes a certain amount of time to get these vaccine trials done appropriately. And I am very confident, all politics aside, that these trials will run the time that they need to run to have a safe and effective vaccine, because there is no like even the companies that make these have no interest in putting out a vaccine that turned out to be not safe or not effective, right? Like this is, there's all sorts of kind of interplays into this. So I think given how much COVID there is right now, I think the vaccine trials will move relatively quickly. And I do think we'll probably have the first vaccine approved, if I had to take a guess, end of this year, maybe early next year, but then it's all about distribution. So I don't think we're very likely to have like, vaccine into anybody's arm in Chicago. If I had to take a guess, first quarter of 2021, probably later in that first quarter, but we're likely to only get, that first wave is probably going to be like healthcare workers, right? And like first responders. I don't think we're going to really be getting into more like of the larger vaccine distribution, more likely until kind of second quarter, if I had to take a guess. I mean, we're planning, let me tell you, my team is planned and ready to go January 1st, if it's here or even before, but I think it's more likely we'll start getting more vaccine, hopefully in that second quarter. But kids, for example, the vaccine trials are not being done in kids. There will be a whole separate thing that happens there. I don't think we're going to be vaccinating kids most likely, maybe until the summer even. And so I don't want you to think of sort of like things will be over at the time of vaccine. All of 2021 is absolutely going to be about rolling out the vaccine, and that's going to be a huge lift for all kinds of partners here. But we're going to need to continue a lot of those protective behaviors even over that year. Masks are going to be with us, so people are going to get the vaccine at different points. And it's going to be this sort of, I think, very difficult from a messaging perspective. Like we got to keep doing the right things. But I do think that, by next summer, I'm very hopeful, assuming that the vaccine turns out to have pretty good efficacy and reasonably long-lasting immunity, that we'll be able to have a lot of this really lifted. We're still also learning what percentage of the population really do we need to get that herd immunity estimate, 60, 70%, something like that, 80%. We're a very long way from herd immunity naturally here. The data for Illinois is like in the 10% range when we look at antibodies. So we really need a vaccine to get us there, but it's coming. I mean, the fastest we ever had a vaccine before was 4 years. That was mumps. So the fact that we may actually have a vaccine a year after a virus is discovered is very fast, but with all of the appropriate safety and efficacy things in place.
So there was a question on the chat about the 2025 action plan is to help communities develop and, in one sense, gentrify or become economically more successful. How do you manage to do that while maintaining the cultural nature of the communities that we now have?
Yeah, it's a great question. And actually, if you're interested in that, I would point you, you can download it right from our website, chicago.gov/CDPH. In the housing section, we actually very specifically talk about gentrification. And there's some interesting work that's been done. I don't know if just to give a sort of a concrete example there, there's this idea of transit-oriented development, and then specifically kind of this equitable transit-oriented development, or ETOD, which is about recognizing that development near, L stops and along transit lines has the ability to kind of drive neighborhood cohesion, be good access to housing, et cetera. But how do you do that in a way that does not lead to gentrification and pushing people out? There are some pretty specific kind of strategies and thoughts around that. But we recognize that as a definite, kind of a definite risk of this. But I do think that the particularly where we look on the south side and at some of the neighborhoods with just very, very, very low, economic, long history of economic disinvestment, very low income levels. I'm most interested in working, we're always interested in pushing resources kind of where they're most needed. And I think some real investment in like the Invest Southwest corridors, for example, if you've heard of that, the mayor's plan there, is about saying, how do we invest in parts of the city where there is need, but also that have the potential to grow economic capacity within a neighborhood in a way that maintains character and does not lead to gentrification. But it's a really good, long conversation on that. And I'd point you, if you want to read some more or see some of the partners working on that, I'd point you to the plan, or you can get involved if you want, especially while it's all virtual.
Amanda, you've been waiting patiently. Did you want to unmute yourself and make your comment?
Yes. So I also put this in the chat, but I was just saying there's been a lot of misinformation that's been going around with the whole, with the virus. And I was wondering if that's something that you've had to combat on your own, and then also how we could go about also kind of fighting that.
Yeah, another really good question. So, I hit this, I touched on just very briefly kind of with the social media piece, but we are seeing an amazing amount of misinformation being circulated in lots of venues, but especially on social media. I think and some of this is actually quite intentional, where I think, there's a pretty strong anti-vaccination movement in the US that I think sees COVID as the big opportunity, right? And we've seen a number of very smart, focused misinformation campaigns is frankly what they are, that tend to kind of take hold and get shared. And, I worry a lot that we, I think with everything that's been happening at particularly on the federal level with coronavirus response, it's been very hard to have clear, consistent messaging that does not seem to be driven by politics. There's been a lot of questionable information coming there. And I've been worried, frankly, that with a kind of a, small but loud group that is working to spread misinformation about vaccines, that we really, and without a very strong counter approach to that, that we could really end up in sort of another tragedy here, where there could be a vaccine available and people not feeling like they want to take it. And we've been following within Chicago and have been seeing significant drops actually in terms of the percentage of people that say if a COVID vaccine was available now, I would be interested in getting it. So what we've been trying to do here is think about how sort of at the local and at the state level, can we build kind of messaging and sort of groups of some expertise to kind of take it out of the federal noise and really have kind of clear information that is honest about what we know and what we don't know. And, once these trials are done, making those very visible. We're working on getting together a sort of scientific advisory committee, which will be scientists and doctors and others kind of here in Chicago, who will be looking at the same data, that the FDA will be using, but will help us I'm confident in the FDA that when something is approved, the right thing has been done. But nevertheless, I don't think people are going to necessarily trust that at this point, and I don't blame them. I want to see the data myself. There's been such a lot of heat and noise around this, that having, I think, some very trusted sort of local voices on the science side, and then pairing them with with trusted community voices. So we've actually started a lot of this already. There's something called the Race Equity Rapid Response Team that the mayor set up initially, that's been all about how do we kind of think about race equity, how do we think about community involvement, all the way sort of through this. They started it, but now we've gone out sort of much more than that. And thinking about how do we pair sort of science voices. I've also got like the health department all kind of deputized already around, you are going to be carrying these messages, like whatever spaces you're in. And I think for you guys too, like we'll be putting together, it's a little bit hard right now because we don't know yet, like when the vaccine is, what the vaccine is, 2 doses, 1 dose, there's a lot of questions, but I think we can talk some now about the process, like how does a vaccine even get approved, right? We have 18 childhood vaccines that have excellent safety and efficacy profiles. What is the process that goes into those? This is in many ways that same process. What's been sped up is actually a lot of the manufacturing and the other pieces around it. And be honest about, when people have hesitancy around this kind of stuff, it's coming from a very real place. So I have tried to do some of this myself, particularly through this Facebook thing. Like it started as a way to not be doing stand-up press conferences all the time. Early on, we were doing I was doing these Facebook Lives every single day, like 7 days a week at the beginning when there was just such a need for information. And at this point, we do them live a few times a week. And then on the other days, I film sort of shorter questions and we translate them into Spanish. And, I try to have like one day I have different sort of guests on who are working on COVID in their communities in different ways or talk about different aspects. And the other one, we pretty much take straight questions. But we're really interested in like developing collateral that kind of speaks to Chicagoans and can help address a lot of this misinformation. I should have said this the first time around. There's a youth survey right now that's up that would be good for you guys to take. If you go to chicago.gov/coronavirus, right up near the top, you'll see there's sort of we're doing some surveying of 18 to 29-year-olds, which have been a group that have had some higher rates of COVID, but also just interested in some attitudes and thinking there. But we've been working on thinking, with folks, your age, about how do we take, like you guys are way better with social media, right? Than my old folks at the health department are in a lot of ways. So we've pulled in a lot of younger folks who have helped really kind of shape this and continue to shape it. So that was a lot of talking, but to say that I do think you're going to see, like we've already decided, no matter what, we've not received any federal funding to do any kind of vaccine, like messaging, campaign, anything, but I was like, we're not waiting. Like we're putting some stuff together, kind of pro bono, getting started on this now. And I do think that it's going to be a real fight here in some ways. And I've been, even with the mayor's office and everybody really saying like, another way Chicago comes out of this stronger is if we have good vaccine uptake. If we could get to a point where like, enough of the city is vaccinated that we can sort of really be moving beyond that. You do that faster, you are able to open faster, right? Like there's real kind of reasons for this, but people have to feel comfortable in it. And the discourse right now is making it understandably hard for people to trust. So, there's a COVID newsletter if you're interested. If you go to the Chicago Department of Public Health site and you're interested, there's various things you can kind of sign up for. But we'll be putting out some messaging and would love to have you guys help share this in your social networks with people you know. And if you know something in this space or you educate yourself, please be that voice of reason, especially on social media, which is playing such a big role, like it or not. So yeah, thanks for the question. I think it's going to be one of the biggest.
A follow-up question. I wonder, Karen Joanne, if you could unmute yourself and ask it yourself.
Sure. Thank you, Dr. Arwady, and thanks for the terrific job I think you've been doing. I've been following you since the beginning. So I'm a faculty member in public health. In fact, I direct a program, the undergraduate program in public health. And it was brought to my attention that one of our very early stage students had access to somebody whom she interviewed in the federal government, very high level health related position, who told her not to trust peer reviewed research. So, this is the kind of thing that we're trying to combat. Yeah. How do we deal with this? Of course, we can produce the process and the evidence and the data, but how do we deal with this?
No, absolutely. And this is, I mean, this is very fundamentally, you know, what I have worried about a lot and continue to worry about is this real sort of not just not paying attention to, but actual kind of mistrust of science and casting major doubt about some of the kind of fundamentals of how we conduct science in this country. And I think that, you know, in some ways, you know, I think the vaccine is going to be a moment of truth here, because it's like, I do think it will be a major scientific achievement. Will people see it as that? Will they accept it? You know, kind of where it is, what does all of this look like? But the misinformation out there is like truly astonishing. And I try to just, again, you know, when people are, because I get a lot, let me tell you, I get plenty of challenges like all the time, like direct stuff and people quoting things at me and, you know, on Facebook and in person and in my email and all the rest of it. And I try to sort of understand where people are getting, you know, getting those beliefs, and try to be not too intimidating when I'm trying to, or not intimidating, but like try to understand that like when people have a belief that is not the one I hold, like it's coming from somewhere and it's coming from a real place. And to sort of understand that, but then also say, you know, in my training, here's what I know, here's what I've done, here's what I've seen work, and try to turn the conversation away from science. The other thing is that I've been really careful. You've probably noticed there, or at least I hope, one of the things we've really tried to do is show, you know, no heat between the state and the city on this, as much as we've been able to. Even if behind the scenes, you know, we're debating stuff and, you know, normal. Publicly, we have worked, I think, very hard to have a unified, science-driven, sober conversation here and talk a lot about the science. And there's going to be people who don't buy into that, but consistency in messaging and having to do that in a way that I think continues to lift up science is going to be just really important.
Joshua, you had a very related comment. Can you unmute yourself and go to video?
And yes, hi, I'm Josh, and I live in about 100 miles in west of Chicago. So, and when you're talking about suburbs, I really don't understand that. But, and I was wondering what kind of relationship you have between in Chicago and the rest of the state.
Oh, yeah, certainly.
Shoot.
So quick public health kind of lesson 101. So there's a state health department, which is the Illinois Department of Public Health. And then every county pretty much in Illinois has its own health department. And sometimes there are even some other, like for example, Chicago Department of Public Health is the city of Chicago. And then there's a suburban Cook County Department of Public Health, which is, you know, different again. So there's nothing like a pandemic to sort of, you know, bring people together in a resource sharing way. There's something called the Northern Illinois Public Health Consortium, which is sort of all of the health departments kind of across Northeast Illinois, greater Chicago, but also out sort of a few more counties. And we have a very active and cordial all the time, you know, who has information on this, who can share on this. Like it's a lot of just, we're all trying to sort of solve these same problems, and anything that is Chicago's problem is like Kankakee's problem, and anything that is Kankakee's problem is Chicago's problem. And then I think, you know, with the state, that's where they, you know, the state is in many ways the receiver of things from the federal government. Also, Chicago actually does receive some direct federal funding, but most of, you know, any testing resources that are available come through the state. Any, you know, the large, like all of this kind of comes through the state, and then the state distributes to the locals. And so, you know, we have I think a good relationship in terms of being on the same page around sort of the high level, what are our goals, what data are we using? I think often, you know, you know, everybody always feels like you need more, like never does it feel like you have enough resources. Like it doesn't matter. You know, we're spending in Chicago $2 million a week testing people. Like that's a crazy amount of money for a health department to be spending. But we're doing it because we have to keep our testing rates up, you know, particularly among uninsured Chicagoans. And so there's always a little bit of like, can I get a little more, you know, what's happening with these tests? Like, you know, there's this sort of, this relationship around resources that I think is always going to be real. But broadly, relations, you know, I think generally things are cordial and everybody's very much got the same goals in mind. And we're all very, you know, it does me no good if Chicago is doing great and like suburban Cook is on fire, right? That's not helpful. So yeah, generally it's, you know, and a lot of public health, like everything else, is relationships and sort of trust and, you know, making sure that like, you know, I know who to call when I have questions, they know who to call, we share things, we support each other. So, you know, it's a pretty collaborative kind of environment generally in public health, which is one of the reasons I like it.
Maybe we could finish out with Lauren DeJulio and Kyle, and then Dean King can end the evening. So Lauren, if you could unmute yourself and make it put on your video. Thank you.
Hi, Dr. Arwady. Thanks so much for being here. I'm one of the advisors in the Honors College, and we do a lot of work with students in terms of just kind of overall wellness piece. And I'm curious, you spoke a little bit about trauma in the lecture portion. So we hear a lot about COVID in relation to like kind of physiology, but how, I don't know, what thoughts do you have about how we can kind of help each other get through this emotionally and mentally, you know, in terms of just overall well-being, because it's a lot of obviously loss of things in the process of everything that's happening.
Yeah, absolutely. It's such an important, you know, that's another whole kind of topic unto itself. So, you know, all of CDPH basically has pivoted to COVID response in one way or another. There's only 2 sections that I said, stay where you are, I'm not stealing you. And that was our behavioral health section, which is our mental health, substance use, and violence prevention section. And then it was our environmental health section. And environmental health is sort of a longer story. But the behavioral health was because we knew early on that in a city that already had major needs in this space, this was only going to exacerbate it, right? And we've certainly seen, you know, you look at calls to domestic violence hotlines, you look at what's been happening around depression, like there are major sort of kind of high level needs here, but also, you know, frankly, I think it's been hard on everybody from a mental health standpoint. Everybody, like isolation, you can't do the things you would normally do. So many things are changed. You can't see loved ones, you know. And one of my hopes, and we've actually been sort of, my mental health team is very good and thoughtful. And first we've worked to like expand mental health treatment access and make sure that we're getting, I mean, there's a lot of stuff we could talk about what we're doing, but I think more, I'm actually very hopeful that actually this pandemic, stigmatization, mental health.
I open up the microwave door after warming up my 4 meatball sandwiches.
Please.
But you just pretend like you didn't hear the dogs ferociously barking at me after I fell down the stairs. Oh, and one more thing. When you're outside my room and my door is closed, and you...
All right, there we go. So I was going to say, my hope is that we will actually, ideally, lose some of that stigma around mental health. Like we've all been talking about the way mental health, you know, has been a part of the conversation. And I'd love to get, I mean, this would be a great outcome of COVID, right? If it's like, we think about mental health in the same way we think about physical health, like everybody's can always be better. And there are, you know, that there are very real things that we can do to work in that space, but being open about it, not feeling ashamed about it, that it is a part of health, as much as it is sort of an absence of disease, I'm hoping will be an outcome. We're playing with some messaging and things around this, which you'll see coming out sort of more around holiday time. But you know, it's been a really hard time. It's going to really be hard, I think, especially for people who are in that highly vulnerable group. I'm very worried about social isolation and all the ways that plays out. But I think for everybody, it's how much we need connection and make sure that we are finding that, even if it's in unusual ways. I think making sure that we're making time for exercise, that we're making time for sleep, that we're making time for eating well, like these are the things that can sometimes go by the wayside, but they're as important for mental health as they are physical health. And then the other thing is, you know, early on, I was always telling people, turn off the TV, right? Now it's calmed down a little bit, but this idea of like over and over and over again, COVID 24/7 is like not helpful to anybody. So we're past that at this point. But still, I think making sure that you're making time, you know, in your life for things that you enjoy, even if they're different from what they are, and not feeling ashamed or guilty about that is really important.
Kyle, you have the last comment or question? Unmute yourself, Kyle.
Okay. So I've been seeing a lot of people suggest that post-COVID that we should be wearing masks for the flu season. Do you think the CDC, the health department, and WHO should suggest that and encourage people to wear masks after COVID?
Yeah, this is one of the, like, I'm very interested to see what happens in this space. I do think we are just going to see a lot more mask wearing in general. Like, I don't know that we will be recommending it. Like, we won't be making the big deal about it that we've made with COVID. You know, people can get vaccines around flu. There's treatment for flu. There's other reasons that make it a little bit different. But I do think we'll be making... we'll be reminding people that wearing masks is one of the ways to help protect themselves against flu and everything. Like, it'll probably have a slightly different twist to it. But I think, you know, the fact that, like, some of the more interesting, like, work I've read on this kind of mask idea is where they've looked at some of the Asian countries, especially that had SARS, right? Which was our coronavirus outbreak before this one. Like, this one is SARS-CoV-2, but like actual severe acute respiratory syndrome, you know, had this outbreak. Big parts of the world wore masks for a long time, and we've seen a lot more mask wearing in Asian countries just broadly. Like, it's just more of a thing, like if it, like, just in the street, out and about. And I do think at some level we're going to see some of that here. What some of the most interesting effects that we've seen of COVID already is that in the Southern Hemisphere, you know, where the seasons are opposite, not just their flu, but all of their like childhood infectious stuff. They're like ear infections and the colds and all the stuff that little kids get, and, you know, they're just germy all the time. All of those saw big drops, right? Like during particularly stay at home, and then have started to come, like, you can map it almost exactly, like where things were relaxed. You can follow, like, literally, here is what it looked like for people to get, you know, ear infections. Like, it's sort of funny when you think about it, but it's really been shown. And it's not about access. It's like, anyway, I won't get into details. But the point is, I think we're going to see some differences in our traditional infectious disease work for at least a few years here. Differences in the respiratory stuff, perhaps differences in the sexually transmitted infections. People are doing different things in that space too. And it's going to be very tempting to blame it all on COVID. We're going to have to be careful, I think, to tease out, you know, what is a direct, what is an indirect, what is probably not anything to do with it. But this is impacting us in ways that go far beyond this. And I think people are going to wash their hands a lot more, which is fantastic. And I think people will probably at some level choose to wear masks when they themselves are feeling ill, or perhaps during flu season, or if they're high risk, probably for a long time.
Dean Keene, we'll let you have the final word.
Commissioner Allwady, thank you so much. What an absolutely illuminating evening this has been so informative. I've gained so much from it. Professor Simpson, thank you so much for this partnership that we've maintained in this series for many years. And students. I hope you've gotten as much out of it as I have, and I want to thank you so much. Best of luck as the season and the pandemic continue to surprise us in unfortunate ways. We really mean it. Good. Thank you for all you do for our community, and best of luck going forward.
Thank you. Yeah, I really, thanks for having me, Professor Simpson in particular, for reaching out. All the students, really good questions, and I'm glad to see you engaged sort of on these issues and paying attention to what's going on. I think, good luck is going to be a big piece of this, one way or the other. We are maybe a third of the way through, the big COVID response. I am well aware that there's a long way to go, and we're going to continue to try to use the preparedness work that we've done, continue to try to think ahead in a month's way and in the year's way. We've got no goal other than getting Chicago through this, in as healthy a way as we can, and work on addressing the reasons, that underlie why we've seen COVID show up the way we have in Chicago. So thanks so much, for everybody's attention. Do check out, our website if you'd like to learn more. One other good potential outcome maybe is that more people will be interested in public health long term. So if that's you, hope to see you, in the future, kind of in this space. It's a really exciting space to work in all the time. We could do a little bit less excitement right now in pandemic, but I love this work. I hope all of you end up, kind of in careers that are similarly, interesting to you in a way that never stops.
Thank you so much, Commissioner.
Thank you.
Good night, all.
Good night, everybody.